being in the ICU, whether it's a ventilator-associated pneumonia, a DVT, a stress ulcer, whatever complications come up. ICU delirium is a big deal, and ICU psychosis is what some people call it. And on this new protocol, we do use, under number 3, we are using the confusion assessment method, which is the CAM-ICU tool, where the ICU nurse will assess patients who are not overly sedated, where they have a RASS of -3 or greater. The nurse will then address the patient for delirium, running through a series of steps. When step 4 is found, this is manifest as disorganized thinking, where a patient is not able to answer simple, what we would consider common sense type questions. The patient is considered delirious, and at that point, that would be kind of a trigger to find some other type of method. Sometimes it would be something like haloperidol to help the patient overcome their delirium and then make it easy for them to come off the ventilator. But I think the keys to this order set are starting with bolus dosing, and not having such a hair trigger on going to constant infusions, which can lead to over sedation. The other important part is the sedation vacation, which is under number 3. Daily sedation vacations are shown to improve ICU length of stay, improve ventilator days, improve improve outcomes from an ICU psychosis standpoint. Having a daily scheduled sedation vacation, in my eyes, is for those reasons critical.
Great. Let's move on. The next one that we were going to look at is neuromuscular blocking agent orders, and this is one that has been worked on, has recently come out, and I have a question in my mind about when is the appropriate, when is this most appropriate to use on a patient. So we're trying to make sure our patients who are on the ventilator are completely immobile. So take us through when you would be thinking about this.
This is going to be very physician dependent, and you're asking me, so I'll give you my my take on this. Patients in the intensive care unit who we consider neuromuscular blockade are going to be patients who are refractory hypoxemia. Okay, so we have them on high PEEP assist control ventilation, or we have them on APRV, or even maybe on inverse ratio pressure control ventilation, and we're having trouble oxygenating the patient despite all of those measures. The patient's on 100% FiO2, etc. And now we've got to figure out a way to make sure that the patient isn't moving, is not using any extra oxygen or anything. The problem is that those patients, that population of patients, is going to have a very high incidence of concomitant steroid use. So, these are going to be ARDS patients who may be in the fibroproliferative phase, or they're going to be somebody who has acute interstitial pneumonia, or a horrible eosinophilic pneumonia, or post-influenza, ARDS or acute lung injury, all of which steroids are going to be considered for, and a lot of times are going to be used for. And the problem with using steroids in conjunction with neuromuscular blockers is that the risk for ICU polyneuropathy with that combination is multiplicative. Similarly to asbestos and smoking, that's not an additive risk for lung cancer, that's a multiplicative risk for lung cancer. Similarly with neuromuscular blockade, whether it's a depolarizing agent or a non-depolarizing agent, those will increase the risk of ICU polyneuropathy. For the patient, that's a huge deal, because that can end up being a several-month course on the ventilator, very, very difficult to wean, takes a long time for the patient to get off. Now, despite that, there are going to be times when we do need to use neuromuscular blocking agents. Despite having the patient on very huge doses, for instance, 20, 30, 40 milligrams of midazolam an hour with 300 micrograms of fentanyl an hour, the patient's still hypoxemic, and we simply can't get them to stop moving without that. That would be an instance where we have to use it. If the patient's on the oscillator, we're going to have to have them paralyzed. A lot of times to initiate ECMO, they're going to need to be paralyzed. So the need for an order set is very, very important, and this order set is very well thought out. It talks about both the initiation and the withdrawal of the neuromuscular blocking agent. And it talks about the importance of making sure that the patient's eyes are protected and the increased risk for decubitus ulcers in an entirely immobilized patient. Now, I've gone through all of the horrors of ICU polyneuropathy with neuromuscular blocking agents. Recently, we did review an article showing safety in its use in the intensive care unit setting in early ARDS, which was a big surprise. Even though in the past we've always thought about these huge risks and therefore been very, very stingy with neuromuscular blockade in the medical intensive care unit setting, there was a recent study published showing safety of, as I recall, cisatracurium in the ICU setting despite large doses of steroids. Patients actually, although it was a trend, it actually seemed like patients might have been able to get off of the ventilator a little bit sooner if they had a neuromuscular blockade in small doses early on.
Interesting. Greg, that kind of leads us into this next order set. It has to do with ARDS and mechanical ventilation in ARDS. When you began our discussion, you were talking about tidal volumes and talking about baro pressure, barotrauma and volume trauma. So take us through this with that in mind as well, because I know that that's one of the main things that this is trying to attack is preventing the barotrauma.
This is incredibly important, in my opinion, for any ICU in any health system to have, is a good protocol for treating ARDS. ARDS is very common just because sepsis is very common, aspiration is very common, pancreatitis is very common, and we take care of a lot of ARDS patients in any one given week that we're on the unit taking care of patients. This all began, as you know, with the ARDSnet trial, and this trial, despite some of the flaws that we were talking about earlier with comparing 12 to 6, and we don't know if 6 cc's is better than 5 cc's, we don't know if 6 cc's is better than 7 cc's, all we know is that 6 cc's is better than 12 cc's. Nonetheless, 12 cc's was the standard at the time, and I do believe that. And 6 cc's was shown to have a dramatic improvement in patients' survival. The number needed to treat in order to save one life using this strategy is only 6, and this doesn't cost anything. I mean, this is different ventilator settings is all we're talking about here. And I think there's several things that are important to know that we need to keep in mind when we're running what we call the ARDSnet protocol. First off, their numbers are not going to be as good. Patients in the low tidal volume group in the ARDSnet study had lower oxygen levels, had higher CO2 levels, had lower pH levels, but importantly, they had higher survival levels, and it wasn't a close call on this. And so it kind of goes back to one of those things that we see in medicine come up from time to time. Taking abnormal numbers and making them normal is not always necessarily the exact right thing to do. What we'll do in the ARDSnet protocol is we'll tolerate PO2's oxygenation, a PO2 of 55 to 80, lower than what some clinicians are used to. Oxygen saturations of 88 to 95% instead of the older standard of keep oxygen saturation 92% or greater or 94% or greater. Just because their numbers look worse initially in the ventilator course, and then those numbers do look worse because your mean airway pressures are lower with lower tidal volumes, those numbers, those worsening ABG numbers, if you will, do not portend a worsening, but rather portend, in this case, improved prognosis. So that's one thing that physicians do need to realize is that pHs are going to be lower, CO2s are going to be higher, PO2s are going to be lower, but more of our patients are going to live on this type of a protocol.